Welcome to the Crescent City, where Vital Options is in New Orleans with ASH, the American Society of Hematology. What does genomics even mean, and why is this important when it comes to blood cancers?
Well, we're in the middle of a revolution in treatment of all cancers, but blood cancers have led the way in many ways because it's been easy to study them, because it's easy to take blood or bone marrow and look at the changes that occur in the tumor cell. The human genome is the blueprint for life, and it encodes everything about us. And cancer is a disorder of the genome in which the malignant cell acquires changes which let it grow unrestrained. Really, we're still in the dawn of this new era, but very quickly the ability to detect changes in the genome within a cancer cell have led, in all of the cancers we talked about, to the development of specific targeted drugs which will go after the Achilles heel of the tumor as defined by the genetic change. And all of the people sitting with me here today, their organizations have been involved very much in helping fund and stimulate and be catalysts for the research which has resulted in the development of these drugs. And even at this meeting here in New Orleans, we are seeing just very dramatic changes, and particularly at this meeting, chronic lymphocytic leukemia based on targeted therapies.
Thank you, Dr. Stewart. So, and Quinn Young, I have to turn to you now. First of all, when you began your work as an advocate in this area, especially multiple myeloma, painful disease, and a disease that a lot of people don't even, you say multiple myeloma and they think you mean melanoma, and you know, so how is your world changing as an advocate and your responsibilities now in educating the public because of the advances we're making in genomics and personalized medicine?
So I started the MMRF over 11 years ago and have had the pleasure of working with Dr. Stewart for all of that time through multiple institutions. And you know, even back then, it was understood by the community that the disease is heterogeneous. So it's not like a CML, which is, you know, largely defined by a single mutation. It's very heterogeneous. But at the time, you know, and the technologies that were available couldn't characterize the disease, the level and the specificity that we can today through sequencing technologies. So, you know, for us, at the very beginning, we were just focused on getting patients new therapy because, you know, 11 years ago, Velcade hadn't even been FDA approved yet. So patients were still receiving, you know, either traditional chemotherapy with steroids or high-dose chemotherapy with stem cell transplant as rescue. So that was our first focus, is how do we work with investigators at academic centers and the companies that were emerging at the time just to accelerate new treatments. And the treatment landscape has completely changed. There have been 6 new treatments approved in the past decade. Survival has doubled. And then together with advances in technologies, we are much better able to characterize the disease. So early on, in partnership with Dr. Stewart and others, we supported a genomics initiative taking tissue from the MMRC tissue bank, which is housed at Mayo Scottsdale, working with the Broden student TGen to analyze the tissue to start to understand, you know, what are some new targets that we might not have seen had we not looked at a big collection of samples. Through that, certainly known targets were confirmed, but other ones like a mutation in BRAF, which is commonly seen in melanoma, emerged. So what we decided after that to do was take on, instead of just looking at samples in time, both relapsed and newly diagnosed samples, to take on an initiative where we would track 1,000 patients over time, collecting all of their clinical data, and then prior to treatment and then at confirmed best response in each relapse, do molecular profiling, DNA and RNA sequencing together with conventional cytogenetics and FISH to try to characterize the disease and figure out what are some different subtypes. Then we have a clinical research consortium of which, you know, Mayo Scottsdale and 15 other centers are part of. Can we then, we're putting the data into the public domain on a gateway. Can researchers who are analyzing the data come up with hypotheses that then can be studied in clinical trials? So, you know, we are trying to take advantage of the new technologies that are available to better characterize the disease, but because it's still fatal, because patients, not many patients live past 10 years. There are some outliers, 15, 20 years out, but sadly some patients are still succumbing after a couple of years. And how do you identify who those patients are and how to treat them?
Meghan and Scott, please talk to us about how the role of molecular genomics, personalized medicine is impacting your world with your patient population.
Absolutely. So there are more than 70 subtypes of lymphoma. So first and foremost, and this actually hasn't changed, we work with patients to educate them to ensure they know their particular lymphoma subtype. So many times we hear stories from patients that they actually can get on the other side of primary treatment before actually discovering what subtype of lymphoma they have. So that's obviously a problem that we've been trying to address as an organization for quite some time. In the era of personalized medicine, we want to take that one step further, and as patients begin to educate themselves about their particular disease subtype, we want to make sure they have all of the information that they need to make an informed decision about their treatment option. And some of that includes educating them not only about particular treatment options, but about personalized medicine, about the long-term implications of personalized medicine on their disease and their treatment.
I think you hit the nail on the head. I mean, a lot of it is education about the options, helping them make informed treatment decisions. We have whole programs in the community locally. We have programs nationally about helping patients understand the role of clinical trials, for instance, as can be an option anywhere along their treatment, and helping them understand and sort of set expectations around, what to expect, what to think about, the questions to ask. You made a great point about knowing your subtype, for instance, the sorts of information you need to gather that maybe they're not hearing when they go to the community oncologist, and maybe they are, but they don't know what to do with it necessarily, or they don't know what questions to ask. So, in our Information Resource Center, we have specialists who are helping them think through all of those challenges and preparing them for the next conversation. Because, there may be, I have information today, but I may have an incomplete picture. And in order to really think about what's the best, I may need a second opinion. That's an important piece of the puzzle for us. So we certainly encourage them to get more educated and help them through that process.
Dr. Stewart, is there a checklist? Newly diagnosed patient wants to know that they are getting state-of-the-art analysis with their tissue. What are the key questions? If they have not yet had their second opinion at a cancer center, what do we need to give to patients to empower them so they know how to engage and ask the appropriate questions of their physician?
I think the patient, the best thing they can do is self-educate and use the resources available online, so that when they do go see their physician for the first time, or when their disease has been stabilized long enough to have a conversation, that they know that they should be asking, in this new era of genomics, have you done the necessary testing to tell me what type of disease I have, and what the potential therapies that might be altered by that information might be.
We have a saying more internally than externally about patients. It's your tissue, it's your data, it's your life. And really making sure that patients, to the extent that they can, have their tissue profile. I mean, even in the community centers, a lot of them are doing FISH, so they should be able to at least see some of the deletions or translocations that are happening. And then there are efforts to, even if you aren't part of COMPASS, that you've already been diagnosed or you're not near a center, we have a community gateway where you can contribute your data, and then we will suggest groups based on how you answer the question of micro communities that might be right for you, clinical trials that are right for your, whether it's the type of therapies you've been on or what your molecular profile looks like.
With people going out and doing a lot of their overall genomic screening, are there tests coming out in the future that will be valuable for patients to know if they are predisposed to a hematologic malignancy?
There are, but it's not. So it's not like BRCA1 in breast cancer and ovarian cancer, where there's very clear-cut genetic predisposition to most blood cancers, unless I'm forgetting one. There are some, like Down syndrome. Children have much higher incidence of leukemia, but that's a pretty obvious diagnosis. So that's not something that's really been quite as obvious. And most blood cancers don't run in families. I think that's maybe the important message. Most of them are sporadic. We don't know what causes them, frankly. It's very unlikely, if you have a blood cancer, that you'll have a family member that's going to get the same thing.
Thank you, all of you, because you are working in a most exciting time. We wouldn't have had this discussion 20 years ago.